just want to say hello and good afternoon to everyone. And thank you so much for joining us for today's training on substance use treatment services. My name is Monica Porter. I'm joined by my colleague, Nicole Thomas, and we work at Homebase, a technical assistance provider for housing and homeless service providers in Santa Clara County. I'm going to be turning it over to the main event in just a moment, but before I do, we'll just go through some brief logistics here. We're so happy to have here with us two speakers from the County of Santa Clara Behavioral Health Services Department. We are joined by Tiana Nelson, Division Director for Quality Improvement Utilization, and Lara Alqareshi, who is our Program Manager for Addiction Medicine Treatment. You are all probably used to doing trainings on Zoom by now, but just in case, some brief logistics here for you. To familiarize ourselves, there should be a menu near the bottom of your screen. We do have everyone muted for now, and we ask that you please stay muted to reduce background noise so that everyone is able to hear the training. We will open up opportunity for you to ask questions. And of course, please do feel free to ask questions in the chat throughout the training. We are recording this training and we will make the recordings available on the COC website. The chat box will not be recorded. We do have captioning available. We thank you in advance for your patience in case the captioning isn't exact, but we do hope that some is better than none. And so we will just ask our presenters, and I'm trying to remind myself to speak at a pace that enables the captioning to keep time with us. If you have any questions during the training or have any technical issues, please use the chat box to message myself or Nicole directly, or send a message to everyone. We will be monitoring the chat throughout the training and will pause periodically to address any content questions. It looks like we've still got some folks coming in from the waiting room, but we're going to get started in just a moment. To make sure that we can all find the chat box, please go to the bottom of your screen, click on the chat function, and you're welcome to just say hello, or to help us get to know each other a bit more. Let us know, what was your first job? Retail. Ooh, ranch hand for a farm. Gymnast teacher, pizza place, JCPenney, balloon girl. These are awesome. Trampoline arena. That sounds so fun. Raging Waters. I miss Raging Waters. Excellent. Well, feel free to keep those coming. But for now, thank you so much for your patience. And I'm going to turn it over to our main presenters.
Hi, this is Tiana Nelson. Can you hear me okay, Monica?
I can.
Yes,
Thank you.
yes.
Okay, because every time that you mute everybody, it mutes me. Hi, everybody. My name is Dr. Tiana Nelson. I am currently one of the Behavioral Health Division Directors for Quality Improvement and Utilization. With our new integration between SUTS and mental health, that division actually used to be separate and called Quality Improvement and Data Support on the SUTS side of the house. I've worked for the county for 35 years, and I'm actually retiring at the end of this week. So the last 21 of those years have been working for substance use treatment services, although before that I also worked on the mental health side. I did direct service for a number of years, and then I decided I wanted to move up into systems work, and that's how I ended up doing quality improvement. Lara, do you want to introduce yourself real quick before I get started?
Sure. I'm Dr. Lara Alqareshi. I have worked for the department since 2002. I've actually done all of my training either at the perinatal substance abuse program or in addiction medicine, which is in addiction medicine, and I now manage the program that I trained in. So I've always really been passionate about women's health issues and as well as recovery. So I've been basically with the same patient population, and some of my patients in 2002 are still engaged with the clinic. So long-term treatment for sure. Okay, go ahead, Tiana. Thanks.
Lara. So I want to just give you a little bit of background before we dive into the slide presentation. In Santa Clara County, on the substance use treatment side, our system of care has really always been an organized delivery system.
Mm-hmm.
However, a few years ago, the state gave us the option to opt into a waiver that would be what we felt beneficial to our clients in giving them more options for treatment, services, and recovery by expanding what became reimbursable services that previously were not reimbursed. But by doing that, we became a type of managed care plan. So if you kind of put in perspective, just thinking about your own health insurance, it's the best way to think about a managed care plan, okay? Some of the services that you have, you go and you don't have to pay a copay. Sometimes if you go to a specialist, you need to get it authorized and you might have to pay a copay. And then some services that you get, like maybe a surgery or something, all of those have to be authorized. And sometimes they even have to authorize how many days you'll stay in a hospital. Well, on the substance use treatment side, our managed care delivery system is very much like that. But what that means is that any service, anybody that comes through that's accepted into one of our levels of care has to meet the medical necessity to come in to those services. We don't get to define what that medical necessity is. The state defines that for us. And in the state of California, to qualify for substance use treatment services, you have to have a substance use diagnosis, okay, from the DSM-5, which is the Diagnostic Statistical Manual of Disorders. And you also must meet the American Society of Addiction Medicine placement criteria. And what that assessment is, it's a broad range, overarching view of different domains, 6 different domains of an individual's life and what they need at the time that that assessment is completed. And it looks at the impact of substances on those 6 areas. It's very thorough. It's an evidence-based practice, and it's nationally recognized by SAMHSA, by NIDA, and a lot of states are actually using the ASAM criteria now. So we are very fortunate that we started using this ASAM criteria long before the waiver, because many counties in the state of California had not, so they had to relearn medical necessity. The importance of the medical necessity is once we say that somebody meets that criteria, then it's the same thing as getting treatment for any other disorder. If you have cancer, there's a treatment that goes along with it. If you have diabetes, there's a regimen and a treatment that goes along with it. It is the same thing with the ASAM criteria. If somebody doesn't meet the criteria, but they are at risk, we can still treat them. It's just that the reimbursement is something different, and we have to keep them very separate from those individuals that have Medi-Cal or do not have any insurance, which are the 2 types of clients that we can accept that meet this level of medical necessity. Next slide, please. So the ASAM gives us several different levels of care that an individual can enter. At the very basic is prevention and early intervention. And prevention and early intervention are not currently paid for by Medi-Cal. However, they're on the map to be paid for by Medi-Cal in the next 5 years. So maybe you all will be fortunate enough to see this, because we do a lot of work at early intervention and prevention. Early intervention is seen in a lot of our ambulatory care and in our physical health settings, where they do a brief screening, they do a little bit of intervention, maybe 4 treatment sessions with primary care. It's a very structured process for brief intervention. But then we have 3 different levels of outpatient, one of which is a lower level outpatient with up to 9 hours per week. Then we have a intensive outpatient, very similar to the mental health side, only our intensive outpatient has many more hours of treatment. And then we have what we call partial hospitalization, which, if you are familiar with any recovery services, it's kind of like a day treatment, like day rehabilitation. And then we go into our residential. We might have to click because I'm not seeing the full slide here. Is the full slide being shown? There you go. Thank you. Next, we have 3 levels of residential treatment. 3.1 is a low intensity, and the client does not need to be what we call in imminent danger, but their environment is such that they cannot remain abstinent from substance, or they can't even reduce their substance intake. Then we have a 3.3 level, which is a targeted population for some of our clients who may have neurocognitive impairment. 3.3 gives you a lot more individual attention, and it's a slower pace. There's a lot of repetition. Some of our patients who have alcohol or may have beginning stages of memory impairment might fall into this category, maybe even some of our methamphetamine users. But that's our lowest percentage that we see coming in. Our highest percentage of residential treatment happens at the 3.1 level. Most patients meet that level. And then 3.5 is an even higher level. Generally, we see these people have criminal justice issues, behavioral problems, a lot of comorbidity, meaning mental health issues, maybe even some physical health issues, and then, of course, coupled with substance use. We have 1 level of withdrawal management, and it is a clinical social model, which is 3.2. And all of the ASAM levels have a number associated with it. There are other levels of ASAM that we do not have in our continuum of care. However, we can refer to those levels if somebody meets the criteria. There are what we call outpatient levels of withdrawal management. Generally, what we find is if we have a doctor that is willing to provide medication when somebody is going through withdrawal, and it can be managed while the person is going to outpatient counseling and getting some withdrawal management medication, then we do that through ambulatory. We do not see a lot of that. Most of our patients do not have medication withdrawal. It's different than addiction medicine, which Lara is going to be speaking to you about. We're talking about somebody that maybe is going through alcohol withdrawals and needs Librium, that type of medication. That's a very short term that helps them to titrate off the alcohol in a much safer mechanism. That would be an outpatient level withdrawal management. There's also inpatient withdrawal management. Thus far, on this continuum, at my level in quality improvement, I have only seen 2 patients come through at this level. However, it just could be because we don't have a setting for that to happen. We actually put out an RFP, a request for proposal, but we had no interested parties. And our public hospital here is not interested in taking on that level because you need to have addiction medicine specialists who know about withdrawal management, who know about what levels of treatment to refer. a lot of these patients too. I'm grateful that we don't have a lot of people that fit into this category. Next slide, please. I thought I saw a question come through. Did you see a question there, Nicole?
There is a question. Does the number correspond with the score that they get on the assessment?
No, it does not. It's just a numbering system that the creators of ASAM came up with. The scoring on the assessment has to do with clinical rating scales. Those clinical rating scales are from 0 to 4, which 4 is the highest level intensity. And on the ASAM, a 1 would mean something that a person could probably resolve with no clinical intervention. A 2 is something that probably needs to be addressed, but might resolve itself within a matter of months, maybe just some coping skills. And then 3 and 4 are getting to higher levels of intensity of treatment and longer treatment terms. Those are the numbers that are associated with the severity and the acuity of what the patient presents. Did that answer? Okay. The types of services that we provide fall into these following categories. We are allowed to do individual counseling, and those individual sessions range anywhere from assessment to treatment planning, crisis intervention, discharge planning. And the reason why we have family therapy there is because the state does not consider family therapy a group counseling. So it rolls up underneath support of the individual. So that's why you see family therapy there. We also do group counseling. In residential, you see a lot of this modality because there are multiple hours of intensity that need to be provided. The ASAM criteria says that 5 clinical hours need to be provided in 1 week, but the state certification says 20 hours of service activities, which fall under a certain category that they have created, must be performed, and at least 1 clinical service every single day for reimbursement. Do we have another question?
There is an ongoing question, but I believe Lara is responding to it through the chat, unless you'd like to.
Yeah, it's just about detox meds or how we're labeling something. So somebody who's using heroin we don't have what's called the 21-day detox program anymore. So I'm just trying to respond so that the person can kind of know the right thing to say to see us and then get referred up to Mariposa. That's all. So.
Right. And when Lara talks a little bit more, you'll see there's a distinction. There are some withdrawal, we used to call them kickbacks in the jail, that actually don't have any medication associated with them. They're vitamin packs. So it depends upon the drug. It depends upon the level of withdrawal. And it depends upon a number of different issues, whether or not a person qualifies for what Laura will talk to you a little bit later, to get treatment for heroin and opiates, versus somebody that has an alcohol issue and may need a temporary withdrawal medication to support them. And then later they may actually get medication assisted treatment like Vivitrol, but she'll go into that in more depth in a little bit. This next piece here that shows what some other services that we have in the medication assisted treatment. The reason why we have this listed here is because in addition to dosing, there are requirements for counseling. And that's the 50 to 60 minutes per month. And then also, we have a level of service called recovery services that is aftercare. And in aftercare, that person can get support indefinitely. Although it's not listed as an ASAM criteria, this is something that the state has found is necessary, and research shows that clients fare better if they are not just dropped off after outpatient counseling and they have some continuing support. In Santa Clara County, that continuing support is specific to the individual. So if that individual wants to attend an alumni group every other week in recovery services, that might be available to them. If they want a 15-minute phone call every week, you know, for the next 6 months, we have that service available to them. What we try to do is actually cater to the individual's need, what's going to help them best in that aftercare service. Okay, next slide, please. So I thought that you all might want to know how our level of services have been impacted by COVID-19, because a lot of people think that it's the delivery system has been impacted greatly. Well, it has in certain instances, but in many instances, there have been some blessings in disguise. And those blessings have been an expanded level of telehealth that Santa Clara County did not have previously. With flexibilities by the state to get reimbursed for telehealth services, and of course, being in the Silicon Valley, you know, hoping that we should have this digital technology, we are able to do video sessions, and we are also able to do telehealth or telephone sessions with our clients. And what we have noticed is their availability has been greater. There's less transportation barriers. Some can be home with their children, so childcare doesn't become necessarily an issue. And particularly with our youth, they're always on the phone. So this has been something that has been a blessing in disguise for us. Some of our providers are still having face-to-face sessions in smaller groups following public health directives for social distancing and for the sanitation requirements that are required. Some of our providers have what they call a kiosk that they've set aside for those clients that may be homeless or don't have access to the digital technology, or maybe they don't have a confidential spot. So our providers are pretty much all open now for in-person sessions for those people that either absolutely need to have an in-person session or are struggling with the technology to be able to have telehealth or video sessions. So most of our services for outpatient are actually happening via telehealth. Of course, residential is on site. So the patients still go there and they have either had a COVID test already, or they get a COVID test while there, and while pending results, they are quarantined until those results come back. And then they go into a cohort of residents that have already been tested. Next slide, please. So all referrals to our residential program are what I kind of described in the beginning about getting surgery or some of those specialists that need to be authorized prior to going in. And residential is something that is required by our managed care plan, no matter what the level of residential, that must be authorized. Although our withdrawal management program has the title of residential in it, it is not considered a residential treatment service. Withdrawal management is seen as an urgent service in Santa Clara County. And although we know that right now we have limited beds and we're looking to expand those, we've gone to the Board of Supervisors to increase those number of beds. Due to COVID, our bed reduction is down because we have to keep those individuals in separate individual rooms. So when they want to go into withdrawal management, they're not getting any medication there. They're getting 15-minute checks. They're getting a lot of social support from rehabilitation counselors that help them work through the uncomfortableness of a lot of emotional distress from coming down from methamphetamine, which is our #1 drug of choice that leads into withdrawal management. Our second drug of choice in this county is alcohol, but we have other resources for alcohol in addition to our withdrawal management program. So we can parse out based on the individual's needs where they would like to go. So their choice is considered, but they still have to meet the criteria of being medically eligible and the medical necessity. The medical eligibility piece has to do with a medical doctor clearing their health. So every provider has a screening that looks at all their physical health issues to ensure that they're getting the proper care that they need, or that they'll make a referral for that proper care. It could be anything from an abscess, from injection of drugs, to somebody who has blood sugar levels that are through the roof and needs to get their diabetes under control. So these are all things that are taken very seriously as people come into our programs, because we don't want to place them in a level of care that they might not be able to participate in if they have a physical health issue, or if they have a mental health issue that might impair their participation. All of that is taken into consideration. Next slide, please.
I am seeing a couple of questions.
Okay.
One, someone missed the part where people can go to get a screening. Is there a specific location or phone number?
Screening for substance use treatment?
Aurelie, you can come off mute if you'd like to. Oh, yes.
Okay. All screenings start through Gateway. And I'm going to have a slide that comes up here. But if there is a problem with somebody getting through Gateway, or let's say you want to advocate for a client, I'm going to give you a little inside number, and you're not going to tell anybody that I gave it to you when you're trying to coordinate care into our care coordination with my QI team. We prefer that the client go through Gateway because we register all of those calls. We call back whoever needs to be called back, or calls that are dropped. We register all of that information, and Gateway has in the 90th percentile of matching clients to the appropriate level of care. That's how we get them registered into our system. So we always have people start with Gateway, and they get a screening right then and there on Gateway, from Gateway, by professionals who have been doing this for years. And then they're actually referred to a level of care where they can get a full-blown assessment.
Thank you.
Next slide, please. Another question?
There were two other questions. Would you prefer I wait or ask now?
No, go ahead.
I'm seeing that someone is working with a veteran who wants more than just a phone call, as they feel they're consuming more lately. Is there the possibility of an in-person session?
Sure. That's a kind of a specialty case. So the first thing that I want to say is, I don't know whether or not this veteran has done any work with the VA, but the VA actually has specialized services that they may want to try before they go through us. They can absolutely go through the county. I just know that for years we've been referring veterans because they can get a lot of that specialized treatment face-to-face with the VA. The screening is never done face-to-face. The assessment, yes. So once the screening has been completed and this gentleman is, or I'm not sure if it's a gentleman or a female, is referred to an outpatient provider, they can actually request that that session be face-to-face, and they will set it up so that happens. We have almost all of our providers are doing face-to-face now when it's requested.
And then in addiction medicine, the screening by the physician, if it's alcohol for medication, that's in person. And so they're also seeing, nurses, and they're actually getting the injection at the clinic. If it's Vivitrol and if it's just medication, they're still initially seeing Dr. Singh, and then they would be scheduled to, we're doing phone, we are seeing patients in person per request. We have this whole pandemic time, so most patients prefer a phone call, but we are seeing patients in person. And they have to see the physician in person, so they are coming in. So.
I'm also seeing what is the best way to support an unhoused individual without a cell phone with Gateway due to needing to call daily.
Okay, so if you're a counselor or a case manager that's working with this individual, the best way to do it is to call with them to Gateway, and then they tell Gateway what their situation is. And then Gateway will refer them to one of our providers that has what they call, it's like an open setting for that person to go on that day to the provider. And they go to the provider. It could be Caminar, it could be Momentum, it could be Proyecto Gardner. They show up at the clinic that day and they can get an assessment in person at that clinic. Any more questions before we go to the next slide? I want to be cognizant of time. I have no idea where we are with time.
There are a few more questions. So what I can do is I can group them all together as we continue to move on to the slides, and maybe during a Q&A at the end, you can address those.
Yeah, that would be great. Thank you.
Wonderful.
Okay, I've already described this a little bit, so I'm not going to spend too much time on this slide, but I do want to mention once again that with our residential services, most of the treatment is done in a group setting. And that's just because everybody is living in the facility together. They do get individual care and they do get family sessions, just not as much as they would if they were in an outpatient setting, if that was the preferred mode of service. So most of these hours are done in group with all different types of topics. And we do have one specialty residential that is a perinatal program that works very closely with referrals from DFCS, social services. And they have a number of different groups that address all the areas of need that these women and their children come to the program. So it could be anything from domestic violence to mental health needs, coping skills for parenting. And that is our Parisi House on the Hill. And Parisi House on the Hill has another specialty program where women can go with their children if those children are up to the age of 5. Once they become school age, they cannot be in the program anymore because the children need to attend school and they come from various districts. But with those women that have younger children, yes, they can come with their children to that program and be in recovery. Next slide, please. And this is probably where we felt the biggest impact to COVID. Because of the social distancing and quarantine regulations and directives from public health and CDC, we had to reduce capacity in our programs based on the way the facility is. A lot of the rooms have 2 beds in one room. And so our largest provider for residential is now operating at a little less than half capacity. They also have to be able to have rooms available for quarantine. All of our residential providing staff has been vaccinated, so I'm really happy about that. And they have been attending meetings with public health to see if maybe the clients might be able to get vaccinated. I know that right now they don't fall in the tier for the vaccination, many of them, unless they're of the right age. But there's been a very strong push in Santa Clara County for substance using patients due to their low immunological systems in being able to get vaccinated sooner. There have been changes to some of the visitation just because of COVID. Some of the visits that social services has set up with moms and their children have to be done via telehealth. Sometimes if the weather's nice, they can do it outside, but they have to wear masks. Just following the protocol that public health and CDC have recommended for residential facilities. And that's not just substance use residential facilities, it's also mental health facilities as well. So a lot of this has had a huge impact emotionally, as it has on all of us. We've all had our own issues with COVID and the impact, but for those that are separated from their families in residential settings that we're hoping to have that support, it's been a little bit more difficult. What they do try to do is set up more phone calls for them, and they try to permit that the social worker allow them to have the visits more on site so that the women or even men in some of our recovery residences don't have to leave the site, because when they leave the site to go to different places, it risks more exposure. So kind of navigating and, you know, having transportation, having to leave the program, come back 2 and 4 has been a little bit of a barrier for what the normal would look like, which is that when you're in residential treatment, or if you are in one of our ancillary housing programs, recovery residence, you are able to go to all of your appointments with the court, all of your doctor's appointments, all of your counseling appointments, all of those things are supported by the substance use treatment programs. It's just now we're having to set these things up virtually for them. Next slide, please. Nice segue into some of our ancillary services. So we have non-emergency services. We do what we call bridge to treatment. So that could be either to a mental health treatment or to physical health. My QI team does a lot of care coordination to support providers who either struggle to get those connections made, and they facilitate those connections. We have a special team that works with hospital referrals so that we can do direct placement into recovery residences and outpatient. But a lot of these patients that we see coming from Stanford Hospital, El Camino, of course, our public hospitals, O'Connor, St. Louis, and VMC, they have direct entry into our residential programs. So they do take priority because many of them have a higher acuity and meet the criteria for residential treatment. But we also have what we call recovery residences. These are the same thing as transitional housing units, but nationally, because they support a sober living environment, SAMHSA changed the title from THU to not be confused with transitional housing for parolees coming out of prison to recovery residences. The criteria to be in one of our 386 beds is that they must be attending an outpatient substance use treatment program, because the funding is directly tied to these recovery residences for the patients to be in some level of outpatient care. COVID-19 impact, again, on some of these is the beds were reduced, but what we've noticed is some of our recovery residences now are starting to build up again. They have protocols in place, and they're getting more full. So we have several of them that are operating over 50% now, with just a few that, because of the way their facilities are set up, are still working at half capacity. Next slide, please. And you'll be getting this, I think you already have this slide deck. This right here is the access point. And if you have a piece of paper and a pencil, I'm going to give you another number as well. This is the starting point, because these are where the experts are, and you're more likely to get faster access through Gateway. However, we have a no wrong door. If somebody were to show up at one of our providers, that provider would either work with them to get them into placement with them, or to call Gateway with them while they are there. And the other thing that I want to mention is we don't have a lot of people dropping in right now, because actually our clients don't want to have face-to-face sessions. So we did a telehealth survey, and we realized that there are still a lot of people that are out there that are trying to abide by the shelter-in-place directives, and Santa Clara County has had some very strict protocols compared to other counties, and those have not been lifted that much. So we did a telehealth survey in Santa Clara County to see how we could improve our services via telehealth and what they were preferring. And they're telling us that they're preferring to do telehealth until the vaccine plays itself out a little bit more, and until they feel a little bit safer going out into the community. The number that I want to give you is not for you to give to your clients. This is for you as a professional to get some facilitation if you are struggling to get through to Gateway. You can call our online QI, and that's a care coordination team for facilitation for your clients, but it must be you, not the client. If a client calls, they're going to be referred directly to Gateway. This number is 408-792-5670. That number is available Monday through Friday from 8 in the morning until 5 in the afternoon. And there is a QIC, Quality Improvement Coordinator, who is assigned that week to answer these calls. When you call that number, it will give you the cell phone of that QIC. And you can call the QIC and you can say, hey, I have this client that went to Gateway. They really want a face-to-face session. Or I have this client that went to Gateway. Maybe they were not as candid about their use, and you really feel that they should be going to residential treatment. What do I do? And the QICs are there to help the beneficiaries, but they're more so there to help you help the beneficiary navigate our system. So keep that number handy, but recognize that they will not get a screening at that number. You will get facilitation with care coordination with that number. Also, there is on our website, and this is a good point to mention about our website. If you go onto BHSD, Santa Clara County, up comes this beautiful website, and there is a mental health side and there is a substance use side. If you go into the provider side of the substance use, you'll see in the upper right-hand corner that it says provider site. You will have access to a number of different resources. Our provider directory is there. You can go into the provider directory by modality. And if you need a residential treatment provider and you hit residential treatment, it'll show you who our providers are. Same thing with outpatient. It's up to date with our most recent providers. Now, what I do tell you is there's a lag time between updating the website because everything gets vetted that goes on the website. But I really encourage you to go and play around. All of our campaigns are on there for prevention. There's resources on there. You can even review my quality work plan and see what are the issues of quality that we're working on in Santa Clara County, specifically related to substance use, what we track, what the state tracks. It gives you a lot of resources that are helpful. Addiction Medicine has a page on there where there's a lot of information as well. So I highly encourage you to get the most up-to-date information to go to that website. Okay, next slide, please. We have the Dependency Treatment Court Assessors number on here. If you have a client that is in Dependency Court and they have a question, we encourage you to have them go through the assessors number because they act as care coordinators and they also are a direct link to the court. These are other additional points of entry, but as I said, even if a client were to walk into one of our clinics, if they were to walk in over to Momentum and say, I need help, they will get help because we have a no wrong door. Next slide, please. Okay, so we have a few Mythbusters here, and let me see how we are on time. We have to go through these very quickly because Lara needs to come up here. So Okay, I see all these things keep popping up thinking there's a question. This is interactive, so anybody that would like to respond to these, please feel free. I guess you can unmute yourself and let us know what you think the answer is. 1, since marijuana and cannabis has become decriminalized and legal in several states, it must be proven to be less harmful. True or false?
False.
Okay, thank you.
False.
Next, we'll go to the answers in a minute. It is worse to inject heroin than it is to smoke it. True or false?
Hmm.
I don't know. I would say
I would
false.
say
True.
true.
Okay. Next one. Ecstasy is just a different form of methamphetamine. True or false?
False. False.
I would say
False.
false.
Okay. Not all drugs are addicting. True or false?
That's
False.
false.
And drug addiction is not a mental illness. True or false?
False.
Okay, let's look at our answers.
True or
See,
false?
let's see what we did. Next slide, please. So for those of you that said false,
Okay, doke.
sorry, I had to unmute myself. Somebody keeps muting me. That means it's Lara's turn. Marijuana is bred with higher percentages of THC than it ever has been in the 1960s. There's a whole lot of research out there. If this is something that's your cup of tea, I encourage you to look at some of the research. And if you're having trouble finding some of the research, send me an email. I will get you some of the latest and hottest articles on this. THC affects the neurotransmitters in the brain, particularly in brain development in teens. And what we're seeing, because of its high percentage of the psychoactive substance of THC that is in the most recent forms of marijuana, we are seeing these extreme effects psychologically. And there's a whole bunch more of physiological side effects, but what we're seeing is even some cases of psychosis. Heroin, false. It is not worse to inject. It is equally as bad to smoke or inject. It does not matter what the method of ingestion is. The damaging consequences of its use are still the same. One way, it might just get in a little faster. Okay, 3, it's true. Chemists who who make ecstasy have about 400 or more plus different chemical structures of MDMA. And the MDMA is what ecstasy is. The MA stands for methamphetamine. Next slide, please. Okay, false. The question isn't about whether a substance is addicting or is not addicting. What we have now learned over the years is it's not about willpower either. Addiction is a neurobiological process that acts on the brain's reward system. Maybe I'll get invited back by Nicole if you want somebody to come back and talk to you about the brain, because that is my main area. I go all over the state. I've gone to different states and I talk about the neurobiology that happens when people use various substances on their brain. But what we do know is that if you take a SPECT scan and you look at what's going on during a craving, you cannot tell whether that person is craving food, whether that person is craving drugs, or whether that person is craving sex. Okay, and last one, false. Addiction changes the brain structurally, both physically and physiologically. That has the same type of issues that people have that have various symptomology of mental illnesses. It is actually classified in the DSM-5 as a disorder. Next slide, please. Okay, you're up, Lara. This is just our gateway number and segue into medication-assisted treatment.
Okay, thanks, Tiana, for that Wow, for all I learned something after being here all these years, or how things change. Okay, so I did give my email address out. I think if people have additional questions, if you just want to email me, I will answer you. If you want a phone consultation or something with a patient, just email me and I'm happy to set up a time with you via Zoom or the telephone. But I want to assist you in getting your patients either into the right level of care for treatment, or at least, getting assessed and understanding the options. I am working in what used to be just the methadone clinic. Now it's called addiction medicine. So primarily we treat illicit opioid use. We have seen a great rise in fentanyl use, which has been very, very difficult to stabilize on methadone or buprenorphine. That's a side note, but patients for screening, patients come to us in different ways. In general, they come through Gateway. They may come through a hospital referral. Patients who are having an opioid withdrawal situation, or alcohol withdrawal situation for that matter, may go into the Valley Medical Emergency Department, and they will be started, if it's a illicit opioid use issue, they will be started on buprenorphine if they meet the criteria, if they're in withdrawal and are using an illicit opioid. And then we would pick them up during the week. So a patient may actually seek treatment for an opioid use disorder at any time of the day, and then they would be seen by us. So, okay, so let's go to the next slide. Okay, so these are the main three medications that addiction medicine prescribes. And there are 3 clinics in the county, 3 locations. One is on the VMC Hospital campus. One is in South County in San Martin, and then one is at Alexian, the old Alexian Brothers Hospital, or in that vicinity. And so I know people have heard about Vivitrol. So Vivitrol is naltrexone in an injectable form. Okay, so a patient may be stabilized on oral naltrexone. They may also be given Vivitrol, it's a monthly injection. And for some patients who are on other long-acting injectables for mental health, it may be easier for them. But people who want to stop drinking or want help with that with medication, naltrexone is very low cost, has been around for more than 30 years, as has methadone for illicit opioid use. Really, the new medication out now is called buprenorphine. So Suboxone is one formulation of it. Then Subutex does not have naloxone in it, so we use that for pregnant patients. So naloxone means that you can't change the route of administration with Suboxone. Okay, if you can't change the route of administration, you can't inject it. So like some mental health medications, if you chew them up, you get the result faster. So with Suboxone, you can't do that. You have to take it pretty much as prescribed or it doesn't work. Okay, so the physicians that I work with, if we go to the next slide, sorry. The physicians that I work with would never say that methadone or buprenorphine or Vivitrol are harm reduction, right? They would say that it is treatment for your opioid use disorder or your alcohol use disorder. So this slide is just one way to kind of look at that, because I mean, my best friend is diabetic and she continues to eat sugar, and I don't tell her her diabetes is a moral failing, right? Or that her insulin is harm reduction. So I think if we can somehow encourage patients to look at getting treatment, and I think a lot of patients feel bad about their substance use and dependence, So it's very challenging. Let's see. So, oh, and then I want to also talk about pain or addiction. Okay, so for the next slide. So most of the patients that I've treated or seen have had some painful condition, whether it's emotional trauma or physical trauma or both, or some form of abuse, or they were system kids. So with any of the patients that end up on methadone, right? Methadone is a parity medication. So that means the patient has tried everything they can to stop using. So likely they've gone to possibly just outpatient with no medication. They have tried to stop on their own. Many people are able to start and stop an opioid. Not everybody ends up on methadone or wants to try that medication or Suboxone. So while the patients may have started with pain issues, if they are coming to an addiction medicine clinic and actually receiving treatment with us, they have an opioid use disorder or an alcohol use disorder, which is a DSM diagnosis. And if they are on medication for it, they have a very severe addiction. So it's not something that they've been able to stop without other assistance. So that's why I also have here is that the addiction medicine clinics, our clinics do not prescribe opioids for pain. Now, primary care can refer patients to a pain physician, and they have different, sometimes they have acupuncture. So, I mean, there's different ways to treat pain. I know that, we've had patients who have a cancer diagnosis or who got on the clinic when they were 30, now they're 50 and they have cancer. Those are patients with a very painful condition, like one patient had bone cancer. So we ended up coordinating his care. So his opioid addiction was remote. He was stable with us, and we had to coordinate care basically with his hospice providers to see that he was in as little pain as possible. And his past opioid addiction, it was a problem. We did have a lot of communication with the provider, so it worked out, and he did pass away, but it wasn't in horrible pain. So okay, so medication is, and I do want to say something about how patients may say, oh, I went to the clinic and I wasn't able to start medication, or they wouldn't start me, or they turned me away, or it didn't work out. And I will tell you, because methadone is an agonist, right? If the person isn't in enough withdrawal, meaning they have to have opioid withdrawal symptoms that are visible, they don't have to be throwing up, but they have to be sick, we cannot start them, because methadone being an agonist, if we put that on top of other illicit opioids, we can overdose the patient, right? So that really is what we're always at assessment. People think, oh, it should be fast. I wish it was faster. It just may take time to get through a history. We're assessing patients off the street daily and trying to see that we start them at a dose that is safe. So it can just take time. I mean, the patient didn't become addicted in a matter of days. It's going to take some time to get them feeling better. So, we do have methadone and buprenorphine and Vivitrol. They are voluntary medications. So this means a patient may start and may be on for a month or two and decide they want to taper off, and they set a schedule with the physician, and then they would taper, and then potentially not need any other medication. We do have that happen with younger people and with buprenorphine. there are what's helpful is there are community prescribers. So primary care physicians that will prescribe buprenorphine for patients who aren't going to be able to come to counseling or just don't, our clinic structure, we have a number of requirements. Our clinic structure just isn't going to work for them. So the good thing is that we will sometimes start patients on buprenorphine and then transition them to a community provider. And then they will stay on the medication, or they will taper the medication with that physician. I do want to say that there are patients, I've worked in this clinic since 2002, and there are patients in this clinic as long as I've been working in the clinic, and we've had patients on, even longer, since I want to say 90. So methadone may be a long-term medication for some. I know it's not always supported in the AA and NA community. And I really encourage patients to figure out where they can get support from, and where, what's going to be helpful for them, because they're living their own lives, or at least trying to. Okay, so the next slide. So this just goes over, okay, so a lot of times, so MAT, medication-assisted treatment, is often interchanged with AMT, addiction medicine treatment. So they're basically the same thing, but if you're looking at just medication-assisted treatment, that would be Vivitrol or buprenorphine or other medications for alcohol withdrawal that our physicians also prescribe. So if it's methadone, it's really narcotic treatment program, which that acronym is NTP. So people will sometimes say medication-assisted treatment and mean methadone, but methadone is a daily medication. It's an opioid, right? So, as is buprenorphine. There's a lot of restrictions around it. So medication-assisted treatment has much more freedom as far as the prescribers go. And with Vivitrol, the person cannot have any opioids on board or any alcohol. So it means, they can't drink for 3 to 5 days. And then depending on what they're using, it's going to probably maybe more than 5 days. Most of the patients we have on Vivitrol would be alcohol dependent people. And we do, any of these medications assist somebody in their recovery. So there's, nothing works all the time for anybody, or we wouldn't have all these treatment options. I do think that the patients who enter into methadone or buprenorphine treatment, they generally have fairly extensive 5 or more years of illicit opioid use. And most of the patients that are coming in are also injecting. So, okay. And like I said, Vivitrol and naltrexone, it's the same thing. The naltrexone is just an oral, and Vivitrol is an injectable. I want to say buprenorphine, we've been prescribing that over 10 years. Buprenorphine is also now approved for pregnancy. Okay, so next slide, which we'll discuss pregnancy. Most of those referrals, if the patient is using illicit opioids, we get them in the next day, and their options are methadone or buprenorphine. With COVID, it has been challenging because the perinatal substance abuse program, we had daycare, and COVID has temporarily suspended our daycare services, but those will be reinstated soon, hopefully. So, Narcan, what's the easiest way to get Narcan? We do offer it at our clinic. Our nurse, if you want to email me, our nurse manager does Narcan trainings to the community. And we had a grant and we gave Narcan to police officers as well as other first responders about a year ago. So if someone wants to email me about the Narcan, I can find out what we're doing. What we're doing with that. I know at the main clinic, CVC, Central Valley Clinic, which is on Enborg, we do have patients walk in and watch the video and get a Narcan box. And we ask patients to call the clinic before they come, or we had a Friday afternoon at 1 p.m. Narcan offering. But let me give you the clinic number. It's 408-885-5400 if you want to call for Narcan. We do give it out at admit also to all patients that we screen, or we offer it. Okay, so what about pregnant women? That's the next slide. Okay, so we just in fact admitted somebody pregnant today. So patients who are using illicit opioids when they are pregnant, the risk really is if they are dependent on an opioid and it's illicit use, the risk if they abruptly stop that opioid is fetal demise and death of the fetus. So it is important for these patients to get into treatment as soon as possible. Our physician who works with the perinatal patients has been there over 25 years, and that the perinatal staff has also been there for an extended period of time. But if a patient, is pregnant and is, I'm going to say past 5 months, they may need to go to labor and delivery if they're having an issue. I mean, we do admit during business hours, but if they're having a withdrawal issue, the VMC labor and delivery, which is, basically the hospital, will deal with them. So, okay. So pregnant women, that's pregnant women. I don't know if anybody has any questions about that. I do see pregnant women doing well, meaning their pregnancies are stabilized. They stop using illicit substances on either methadone or buprenorphine. You cannot use Vivitrol during pregnancy because it blocks any analgesics. But methadone and buprenorphine, I have seen both the mother and then they seem to have less stays in the NICU or need less neonatal care. So that's a positive. Okay, so, and then the next slide. Okay, so this is just some information on our treating practitioners. All of the physicians, I want to say, have been with addiction medicine, gosh, probably 15 or more years. So yeah, they've all worked with patients for an extended period of time. So I don't know if anybody has any questions. I do think that admit or starting a medication is challenging, for anybody. And I know that a lot of times patients come in and just want to immediately be better. And I wish that we could stop their, withdrawal and they wouldn't have to go through some of the unpleasant stuff. And there's no perfect medication. So, I would just encourage patients to get into treatment and find a treatment provider that they want to work with. And there are different choices as we have different clinics and different physicians and then different counselors as well. So I don't know if anybody has any questions about any of this. If anybody wants to type any questions or if there's anything else I can answer. Okay. Well, that's about what I have for this presentation, unless anybody wants to ask anything. Oh, Vivitrol RX.
I have a question.
Okay.
Everybody else is quiet. So one of the biggest barriers that I'm encountering in Warren Gilroy is
Mhm.
that a lot of our opioid users, for example, some had success with Vivitrol and want to do
Okay.
that again. But the requirement is that they have to be completely withdrawed before it can be given. And the Valley Health van will give them the Vivitrol shot.
Yes.
But withdrawing in a tent with no bathroom or toilet is a huge barrier. We have a group of about, I want to say there's probably about 8 of them right now. And I've asked Gateway specifically, like, is there a hotel voucher program? Is there some facility where they can detox and then be given Vivitrol? And that seems to be something that's really missing to getting people connected to treatment.
Well, I guess they could go. Oh, sorry. Go ahead,
ahead.
Tiana. Go ahead.
We have the sobering center. The problem with the sobering center, and that's mostly alcohol, although they will accept some methamphetamine, is that they can only be up in that program for 23 hours and 59 minutes. They can't be past that. And sometimes I think what happens, you're right, that there's a gap in services here, because a lot of times some of these patients will go to withdrawal management, but they don't medically meet the criteria because they are withdrawing. And so they're either sent to the emergency room or some other urgent care or express care. And so we don't have a place where they can go and receive any type of medication. I'll tell you, we've been lucky in a few cases where we've sent somebody over to the ER and the doctor has given them a prescription for Librium to clear them to come into our social model withdrawal management. But those beds are impacted. And that I can't tell you how long I've worked on that issue in terms of quality improvement. But with the county going into a deficit, we have yet to hear whether or not they are going to give us more money for beds. I told them they need more withdrawal management beds before. Yeah. We don't have the numbers, so we need residential beds. We have the numbers to show the Board of Supervisors we need these withdrawal management beds. And then we have a medical collaboration, so here's some hope, where we are talking about expanding. We've expanded into the ER, we've expanded into ambulatory and into the hospitals. The problem is some of these people go in, they're in there for a short time, they go back out and they're drinking again before we can get our hands on them to initiate treatment. So I totally hear what you're saying, and you're right. If I were asked to do a gap analysis, those are the two areas where I would say that we have a gap in the system of care. It's just that they are really caught between that rock and that hard place. I don't know, Lara, do you know of any other resources other than what I just mentioned?
No, I don't. And it is because they can't give a Vivitrol injection,
right,
until the alcohol is cleared, which is why there was patients started in the hospital where they were clear of alcohol and it was safe to start. So I think if it's an opioid problem, I mean, you're up against the same thing. They have to be, and yes, that I understand if they're going through withdrawal in a tent, it's not really ideal. It's not realistic.
I'm seeing Dolores has raised their hand as well for a question.
Yeah, so I had a question about how to support, I work in an ACT program. So sometimes with some of our clients, when they're willing to get some support, we call Gateway with them, and then we kind of see them pretty regularly after that and support them, and calling Gateway and kind of wrap around them with a little bit more support. But what's happened to us sometimes, by the time they get the next step with Gateway, they haven't used in a few days, and then they don't qualify for like an inpatient, and then it kind of goes back in a circle. And so I don't know how best to support the client, because it's like, we've got, they got to the place where they're like, okay, like I'm ready to call Gateway, and they kind of make a safety plan with us on not, trying not to use, and kind of, and it kind of, sometimes it works, especially when we support them more, but then by the time they get to do the next step of Gateway, then they no longer qualify, like for a higher level of care, if that makes sense.
I'm typing something similar to somebody right now, I think. So let me see if I can answer Jenny's question and what you just said. So in instances like that, and that there's, Jenny's question is, if a client has been in these treatments off and on and still having severe problem and loses their housing, what housing options are there? So first of all and foremost, if I have to say this disclaimer, substance use treatment services is not a housing option, okay? What we do have are recovery residences, but based on what Jenny's thing here says to me and what I think it was Liz that just shared that. I'm sorry, I missed the name because I'm trying to multitask. It seems to me that our care coordination team would help with that, because what's happening is Gateway has a subset of questions that they're just missing that cutoff. But if you call the care coordination team and you say, hi, Gateway referred us here. I know the history of this client. This client has been to House on the Hill. They've been to House of Grace. They've been in and out of outpatient treatment. And, we'll have a record of all that. The care coordination team will. And then the care coordination team may be able to get that person into residential treatment, get them on the wait list. They will work with the screening and they will coordinate that care at that point. That's the type of call that I would ask go to the care coordinators when you see that cycle. Now, the other thing is with the recovery residences, if it's somebody that you don't know that they have this history or not, but they need to be in an environment that is supported by sober living, then when you call with the patient, when you call Gateway, from that get-go, tell them, we are looking for an outpatient referral and recovery residence referral. If that starts the chain, Gateway will get a message to the outpatient person. On that first visit, they can start with the recovery residence referral. We were doing fine, with our recovery residence referrals until COVID hit, and then the capacity was reduced. So that I can't do anything about, but I can tell you, we have a revolving system that we were doing great. We had very low wait list. Now, of course, our wait list is very long for both residential and recovery residences because of COVID. And that's the sole impact. That has nothing to do with an ebb and flow, because we had enough beds for residential and we have 386 beds for recovery residences, and they're only up to 90 days with some possible extensions. I've told Office of Supportive Housing, hey, if you've got somebody that's coming up on that 90th day and they still need another month, you can coordinate through my team, the capacity management team, to get an extension at that recovery residence until that other housing option comes. They're not going to throw somebody out on the street when they know that they've got a housing option coming in the next few weeks. So, but I unfortunately, I can't do anything in terms of capacity with COVID. Hopefully that answered your question too, Jenny.
Yeah, it did answer. Thank you. And I had another question. I used to actually work at Parisi before, and now I'm on the ACT team. And one thing I saw happen was, on the ACT team, it's a high level of mental health. And sometimes we had to discharge clients from Parisi because of the psych meds they were on. And sometimes I get worried about when we're referring clients to Gateway, if their psych meds are going to interfere. Is there ever like a list of what psych meds or anything so we could help with our psychiatrists on our team to try to coordinate so that doesn't interfere once they actually get into a program?
I'm going to tell you, if somebody is stabilized on their psych meds, no program better kick them out. I don't know how long ago, but that didn't happen under my regime. Because if that happened under my regime, it wouldn't happen. What we see is if somebody is not stabilized and then their abstinence time starts to increase, the mental health symptomology surfaces. And I cannot tell you how many coordinated care efforts I alone have made to try to get some of these clients into crisis residential treatment on the mental health side so that they can stabilize first on that medication and then really, really benefit to come back to the residential program. I've worked very closely with Mariposa and I've worked very closely with Pathway House on this. Now we also have Telecare, and Telecare actually has, they see AB 109 men. It's all criminal justice men, but they also have beds up there for crisis residential. So if they have somebody in crisis residential that has a substance use problem, they can move them right next door into a bed for residential treatment. It's the first of a kind in since I've worked for SUTS in the last 21 years that we've had that kind of referral system. But nobody should be getting kicked out if they're on psychiatric medication and they are stabilized on that medication going into treatment.
And I will say
That should-
too, yeah, that the NTP or medication assisted treatment, we refer to our in-house psychiatrist who will stabilize or pick up, you know, whatever meds the patient was on. But we refer to mental health too. And a lot of our patients are on psych meds and one of our medications. And I don't see there's not really a conflict. I mean, if you're going to talk to me about benzodiazepine use for anxiety, that is not a match. Right.
Right.
So that, but outside of
Medication assisted treatment, not with,
yeah,
that's not going to be an issue with somebody that goes into residential treatment.
right.
I do know in the past there were issues where they were doing that. And I also know what happened in recovery residences. Not anymore. We make we actually get on our providers when we see things that even come close to things like that happening. So that should not be happening.
Well, and we are coordinating, you know, the MAT patients, we do coordinate between physicians who are, so Suma Singh is prescribing Vivitrol, for example, and then Alqareshi is doing the psych meds. We do coordinate. I mean, you know, we all do, we send notes back and forth, and then the counselor is also involved with these cases. But we've had, I think, just more success with patients on either an agonist like methadone or buprenorphine and following up with psych care, actually doing, you know, maybe stopping methamphetamine use on a Wellbutrin, Prozac, Zoloft, or, you know, general SSRI or SNRI. You know, we've seen overall pretty good success with the patient motivated, or patients who have had, a lot of our patients who come to us have previous psychiatric diagnoses, so bipolar, major depression, anxiety, and we will get them back to a mental health medication that they may have been prescribed successfully in the past, or they can be reassessed. So I'm seeing less bias against, you know, mental health meds as well as addiction medication, which is really good.
Yeah, I agree.
But it's, you know, it's
hard. It is very hard because
it's hard.
Hopefully with the integration that is supposedly happening, and I've said this, I've worked for the county for 35 years, and I've said, if we could just have direct referral from substance use into mental health and mental health into substance use, a lot of these problems would be avoided. Part of the problem when somebody has a acute or overt mental health symptomology, and if they go to a provider, they can't benefit from the treatment. And so it's like a chicken or egg, and you know, they are referred back to mental health. this is where I see a vicious cycle going. They go to medication, they come over, they start to work on substance use, they go off the medication, or they're using the substances again and they go off the medication. And so, I mean, really with integration, I'm hoping we do have 4 providers now that do co-occurring care. Momentum is one of those providers that does co-occurring care. Gardner does co-occurring care. Kaminar, Family and Children's Services, for those of you that don't know about the merger named to Kaminar, they do co-occurring care. Health Right 360 has a mental health contract and a substance use contract. So they are a little bit more adept. And what they recently piloted 2 years ago now, they allowed Kaminar to actually have direct referral of their clients between the 2 programs, keeping in mind that they had to report capacity to both call centers. Well, the call center is now going to be integrated. So that should also be another step towards getting patients at the outset where they need to go. I don't think that, unfortunately, there's so many scenarios. I don't think we're going to be able to get to all of them today. But I will tell you, a lot of the scenarios that you're bringing to us, we have care coordinated, or we're working on solutions, or we've brought them to the county executives to show that there are these gaps and what we need to do. Unfortunately, the housing crisis is a greater social issue way beyond substance use. And who knows, maybe at the end of this week and I retire, maybe I'll go over on that side and try to do some work there, because Lord knows we need it. But I hope that today's presentation, I see there's still questions coming in and I apologize. Lara has graciously accepted. Lara, since my email will be gone in a week, I'm still willing. I'm going to be taking a 3-week vacation, but I'm still willing to get back to people, and I can help you with the answers to stuff that comes if that works for everybody.
I'll get somebody to help me in QI if you're not around too.
Thank you.
So,
sorry, Laura, did you want to say
something? So I'm seeing this question from Darlene. So I mean, I understand you're trying to assist the patient with the gateway assessor, and the assessor is really going to want to have feedback from the patient. So if they're experiencing psychosis due to use, it's going to, I mean, these gateway assessors are health services representatives. They are not mental health clinicians. So ideally, I mean, I would probably push that through care coordination if the patient is unable to, really stop using. So, and then somebody else has got, you've had your hand raised. Yeah, okay. Go ahead. Go ahead, ask.
Liz, I believe you had your hand up.
Yeah.
Just a quick question. We've seen quite an increase in chronic medical care management of clients who are being prescribed naltrexone for conditions like chronic fatigue. And some of these clients come saying, I guess a lot of the university clinics, specifically Stanford and UCSF, et cetera, clients are being told, although this is a new approach to managing pain and any symptoms that fall under CFS, that there's a possibility for dependence. I'm just wondering in general if you guys can speak to and clarify if there indeed is a likelihood for dependence of naltrexone for non-medically assisted treatment, non-addiction.
It's an antagonist.
Yeah, that's.
So buprenorphine, yes, you are going to be opioid dependent. Methadone, obviously you are, but naltrexone, it's being prescribed for chronic fatigue.
Yeah.
Off label.
Yes.
Okay. So that's not ever, I don't know that that's ever going to be why wouldn't they do a antidepressant or an SNRI or?
I think these are, much more complicated, dually diagnosed, comorbidity kind of cases where these are clients who have been to several specialty providers.
Oh, so they haven't been successful with a more normal medication regime.
Absolutely. Yeah. And I figured that there wouldn't be a dependence from the
No, not.
instant treatments perspective. Yeah. I just wanted to double check. So thank you for answering that.
Yeah, but you'd almost, well, I guess, I mean, I understand chronic fatigue. I mean, what is the person just perpetually fatigued? I mean, that's, I don't know. It sounds like there's got to be, I don't know, a lot of other stuff going on mental health wise. And
that's what I'm thinking, that there's got to be something else. It's like when they would start Eleville for back.
So I just want to say, perhaps Liz, if you could stay on for a couple minutes after, then Tiana and Laura can address this. But just to everyone else who attended, thank you so much for attending. We're definitely going to send out an email with the recording, with some of the resources that were shared today. So that will be available. And we're also going to notify you when it's all posted on the COC website. I dropped a survey link in the chat. It would mean a lot if you could fill it out. It takes a couple of minutes, really helps us better tailor our trainings for the future and make sure we're bringing you trainings you want to see and you find helpful. Thank you so much, Tiana. Thank you so much, Laura. I'm sure everyone learned a lot. And yes, thank you for your time. And Liz, if you want to stay on.
So everybody can say I was a bad trainer, so you don't have me back. No, I'm kidding. You can say no. Okay.